In the summer of 1932, the United States Public Health Service announced a new program in Macon County, Alabama. It was presented to the press and to local officials as a free healthcare initiative for African American men who had tested positive for syphilis. The language was hopeful. Doctors would be paid, examinations would be thorough, and the community would benefit from early treatment. Behind that public promise lay a different intention. Officials of the PHS, eager to study the natural course of an untreated infection, deliberately designed the project as a long-term observation. They recruited more than 600 men, most of whom were sharecroppers or laborers with limited access to medical care. Consent forms were vague. Participants were told they would receive the best available treatment, yet no plan was ever made to provide the therapy that had become standard elsewhere. The study began under the auspices of scientific curiosity, but its foundation was built on a hidden agenda, one that would shape the next 4 decades of American medical history. The early 1940s brought a breakthrough that reshaped the treatment of bacterial infections worldwide: penicillin. Clinical trials confirmed it as an effective cure for syphilis, and by 1944, the drug was widely distributed to hospitals and clinics across the United States. For most patients, this meant a swift end to a disease that had once been fatal or disabling. Within the Tuskegee cohort, however, the new therapy never arrived. Dr. John Heller, chief epidemiologist for the Public Health Service, argued in internal memoranda that halting the study would destroy a unique data set. He wrote that the scientific value of observing untreated disease progression outweighs the immediate benefit to individual participants. The PHS leadership endorsed his view, and an administrative decision was made to conceal the availability of penicillin from the men under observation. The drug remained stored in government warehouses, its existence known only to a handful of officials who signed off on the secrecy. World War II sent many young men from Macon County overseas. Some of those recruited into the Tuskegee study returned as veterans, carrying medals and new expectations for their rights as citizens. Ironically, these veterans were often able to secure better medical care through the Veterans Administration, where penicillin was administered without hesitation. Their improved health starkly contrasted with the deteriorating condition of their peers who remained in the study. Families began to notice the disparity. A brother who had served abroad lived a relatively normal life, while another who never left the county suffered progressive neurological damage. The inconsistency could not be ignored. It highlighted the ethical chasm between a government that promised care and one that withheld it for the sake of data. Within the surrounding medical community, unease grew. Local physicians, many of whom were African American and served the same neighborhoods as the study participants, started to document unusual patterns. Patients with syphilis who never received treatment, progressive disease despite repeated visits, and a steady rise in complications such as blindness and heart disease. Dr. Eleanor Watkins, a physician at a small clinic in Tuskegee, kept confidential notes on these trends, yet speaking out carried risk. The Public Health Service wielded considerable influence over funding and professional advancement in the region. Rumors of retaliation, loss of grants, blacklisting or worse, silenced many potential whistleblowers. Still, the quiet accumulation of evidence formed a foundation for later exposure. In 1969, a member of the PHS research staff, troubled by the ongoing deception, copied internal memos that detailed the decision to withhold penicillin and sent them anonymously to the African American Community Coalition, AACC. The coalition, already active in civil rights advocacy, recognized the gravity of the documents. They began compiling testimonies from families of participants, cross-referencing medical records, and preparing a public demand for accountability. For months, the AACC worked behind closed doors, fearing that the government would attempt to suppress the story before it reached a wider audience. The leaked memos described Dr. Heller's rationale, the administrative orders to keep the drug out of reach, and the systematic denial of treatment even after penicillin became widely available. When the coalition finally released its findings to local newspapers, the headlines sparked outrage across Alabama and beyond. The revelations could not remain confined to regional press. Senator Margaret Ellis, a member of the Senate Committee on Health, Education, and Welfare, requested an emergency hearing in 1972. She summoned PHS officials, Dr. Heller, and representatives of the AACC before a panel of lawmakers and journalists. The hearings were televised, and for the first time the nation heard survivors describe the pain of watching loved ones deteriorate while doctors claimed there was nothing to be done. Senator Ellis pressed the agency's leadership. How could an institution sworn to protect public health authorize such neglect? Under intense scrutiny, the Public Health Service finally admitted that penicillin had been deliberately withheld and that the study had continued without proper informed consent for 4 decades. The admission marked a turning point. The veil of secrecy was torn away, and the federal government faced immediate legal and moral challenges. In the wake of the hearings, survivors and families filed a class action lawsuit against the United States government. In 1974, the Department of Health, Education, and Welfare agreed to a settlement that provided monetary compensation, lifetime medical care, and a formal apology. Beyond financial restitution, the scandal prompted a profound reassessment of research ethics. The National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research was convened, leading to the 1979 Belmont Report, which codified principles of respect for persons, beneficence, and justice. Institutional review boards, IRBs, became mandatory for any study involving human participants. These reforms aimed to prevent a recurrence of the Tuskegee tragedy, embedding safeguards into the very fabric of American biomedical research. Decades later, the shadow of the Tuskegee Syphilis Study still lingers in the collective memory of African American communities. The betrayal eroded trust not only in government health programs, but also in private medical institutions that were perceived as extensions of a system that once withheld life-saving treatment. Contemporary public health initiatives, vaccination campaigns, clinical trials for emerging diseases, and efforts to address chronic health disparities must grapple with this legacy. Researchers now recognize that building trust requires transparency, community engagement, and an unwavering commitment to ethical standards. The story of Tuskegee serves as a stark reminder. Scientific ambition divorced from moral responsibility can inflict wounds far deeper than the disease it seeks to understand. As we look forward, the lessons of those 40 years of deception compel us to ensure that medicine serves every human being with dignity and honesty.